The right ventricular outflow tract, also known as the infundibulum, is a distinct anatomical and functional entity of the right ventricle. It acts as the conduit between the trabeculated apical portion of the right ventricle and the pulmonary artery. But its unique structural characteristics make it a primary substrate for several significant cardiovascular pathologies. The RVOT is a truncated, cone-shaped or funnel-like structure located anteriorly and to the left of the aortic root. It differs from the inflow tract of the right ventricle in both macroscopic appearance and microscopic architecture. Its proximal border is defined by the crista supraventricularis, a thick muscular ridge that separates the outflow tract from the tricuspid valve and the rough trabeculated inflow tract. Its distal border is the basal ring of the pulmonary valve. The RVOT is composed of two main sections. The septal component, posterior and rightward aspect, which essentially forms the superior portion of the interventricular septum. The freestanding infundibulum, the thin-walled anterior and leftward free wall. Unlike the main body of the right ventricle, which has a complex intersecting meshwork of muscle fibers, the myocardial fibers in the RVOT run longitudinally and parallel to one another from the epicardium to the endocardium. The endocardial surface is relatively smooth, lacking the dense, coarse trabeculae carne seen in the apical right ventricle. The epicardial surface frequently contains variable amounts of adipose tissue. RVOT is the most arrhythmogenic region of the structurally normal heart. Its embryological origins, derived from the embryonic bulbus cordis, thinner walls, and distinct electrophysiological properties make it highly vulnerable to both functional and structural disease states. Idiopathic ventricular arrhythmias. The RVOT is the origin site for roughly 80% of all idiopathic ventricular tachycardias and premature ventricular contractions in patients without underlying structural heart disease. These arrhythmias are typically driven by cyclic AMP mediated delayed after depolarizations causing triggered activity. They are often provoked by exercise or catecholamine stress and are classically sensitive to adenosine. Because the impulse originates superiorly, anteriorly, and from the right ventricle, an RVOT-VT produces a characteristic left bundle branch block morphology with an inferior axis, that is, tall positive R waves in leads 2, 3 and AVF. Arrhythmogenic right ventricular cardiomyopathy. RVOT is one of the three classic points in the triangle of dysplasia, along with the RV apex and the subtricuspid region affected by ARVC. The region is highly susceptible to progressive fibro-fatty replacement of the myocardium. This creates a substrate for macro-reentrant ventricular tachycardias and can lead to localized wall motion abnormalities, dilation and aneurysm formation visible on cardiac MRI or echocardiography. Brugada syndrome. Recent structural and electrophysiological mapping studies have localized the primary arrhythmogenic substrate of Brugada syndrome to the epicardium of the RVOT. Subtle structural microabnormalities, increased epicardial fibrosis, and localized conduction delays in the RVOT epicardium are responsible for the characteristic curved ST segment elevation type 1 Brugada pattern in the right precordial leads V1 to V3 and the increased vulnerability to ventricular fibrillation. Congenital heart disease. The embryological development of the infundibulum is complex, making it a frequent site for congenital anomalies. An example is tetralogy of Fallot. The hallmark of this condition is the anterosuperior deviation of the infundibular septum. This displacement causes subvalvular right ventricular outflow tract obstruction or infundibulous stenosis, which dictates the severity of right to left shunting and clinical cyanosis. Implications for invasive interventions. Catheter ablation. The RVOT is a frequent target for radiofrequency ablation of symptomatic PVCs and VTs. However, its exceptionally thin wall, often less than 5 mm, requires precise power titration to prevent cardiac perforation. Furthermore, the posterior or septal RVOT lies in close proximity to the aortic root, specifically the right and left coronary cusps and the left anterior descending coronary artery, demanding meticulous electroanatomical mapping before ablation. Physiological pacing. To avoid pacing-induced cardiomyopathy, often caused by traditional right ventricular apical pacing, the RVOT septum is frequently utilized as an alternative pacing site. Pacing from the RVOT septum engages the conduction system more naturally, resulting in a narrower QRS complex and better ventricular synchrony.